name is Shelley Hayden. Yeah. And I said, I'm literally lecturing for her class. She's going to be there. She said she knows everything. So I didn't tell her about the embedding. That was fun.
I've worked with her 5 times. It's really hard, and either it's going to work or it's not, and I'm not going to use it. It has to.
I have flipped back and forth and practiced it.
That
should work.
Yeah,
but it's
that
okay.
will work. That I know will work.
Speaking of which,
okay, I'll let him get their thing. You know what? I'm just going to have prayer and start, and then if we end up having 5 minutes at the end, we probably won't. I'll talk about the class. If not, I'll tell them I'll talk about it next week.
2 hours worth, especially if they're not.
You don't?
No.
Oh, good. Okay.
I mean, if they're very chatty, maybe, but I typically find that most classes are not.
Yeah.
So no, take all the time you need.
Okay.
I'm just going to relax right here.
Okay.
Do you need to sit here at all? During your time?
No, I'm really not going to take. I'll probably take about 10 minutes.
Okay. All right.
They've had my class before. So.
Okay.
But I'm going to let them all get their food.
Okay.
I'll give you probably 7.
Do they start their block rotation this quarter?
July 9, I think is the first day.
Hi, how are you? Good. Ready for some more anesthesia today? Are you sore?
A little bit.
Yeah.
Just right here.
Oh, interesting.
Which that was such a breeze. She went in quick. It was done. There was a movement.
Probably because I went quick?
I didn't even know you were right there.
No, I think sometimes just type of killing.
She just chatted me and just it didn't feel like that when you did it.
Touching the periosteum probably there,
Which last session I got sore.
Okay.
I think I just tend to get sore.
I get sore sometimes, and sometimes I don't. So I get sore sometimes. Sometimes the periosteum is a little just tender where it was injected. I don't know what makes the difference. I saw you give it. It wasn't your.
No, it wasn't you. I think, like for me, I know I haven't been taking care of my body as far as eating and working out, getting enough sleep. So I think all that stuff matters in my pain. So maybe.
Yeah, I know.
Maybe it's me.
I'm working on a better diet, so there's less inflammation and feel better.
I know.
I've got to be able to pick up all my grandchildren. Yeah.
Yes, all your grandbabies. How many?
2. It is really fun. Because you have babies or have had.
I still love watching my mom with my children. It gives me all teary-eyed. And it makes me
Yeah, I know my kids. I know my daughter's perception of me or respect, whatever, has risen since they have children. I go, Mom, how'd you do this with 4?
to my mother-in-law too.
Yes, right. No, it's good all around. It is. Every quarter is like, I know.
Less stress for me.
Yeah.
Shelley,
Yeah.
these are juniors.
They're brand new, 3rd quarter. I
They come
mean,
as seniors, but their first quarter of being a senior.
no, not yet.
No,
Oh, what?
they're juniors now, so when they come to HIV in the summer, it's their first quarter
Yeah,
being a
we
senior.
kind of call it, we don't call them seniors yet because they haven't gone through their OSCE exam. And so once they've gone through their OSCE, then
Which is when?
late July, August.
Interesting.
Yeah.
So some of them come as D4s. Some of them come as seniors. As soon as they pass OSCEs, they become seniors.
That's basically how we think of it. So summertime, they're kind of interim.
I have them as seniors. I think
That's
somewhere.
fine. That's fine. Totally fine.
Always
It's
good
kind
to
of
understand it.
It's kind of because we have some really heavy OSCE exams to really kind of separate if we're having a problem too. And we're pretty strict on that exam on pushing them forward. So, or then we do some pretty heavy remediation if not. And so that's kind of how we look at them. I'm not sure the technical term went with Barbara, but it's totally calling them seniors. The seniors are gone, so they're seniors, kind of, sort of.
Interesting. Okay,
Yeah.
good to know.
Yeah, that's how we do it. Okay, did everybody get something? Okay, we want to get started. Okay, I'm going to go ahead and start since we have a guest lecture today and we want plenty of time. This is a really great lecture. We're so thankful that Dr. Cho came to share with us. She actually runs the grant for the HIV clinic that we have. We are really lucky, I think, to be blessed here with the opportunity of going to a clinic that is especially designated for HIV or AIDS patients. And so you don't start that clinic or that rotation block until this summer. So this gives you a lot of information ahead of time. Are you actually there when they start rotating or sometimes? Sometimes. But this lecture will help you both be prepared for that clinic, but also just be prepared if you were to have an HIV patient at any time. What I find is that HIV, the term, sounds kind of scary if you're going to treat a patient, but I believe that today, after your lecture and after understanding the information better, you will not have any serious concerns about going to the HIV rotation. You'll understand what it takes to protect yourself and to protect the patients before and after the patient that you might treat. And I find the information very, it's kind of calming because the concerns then are decreased. And the same thing we always talk about, more education about a topic, then the better you're able to communicate with your patient who may have that, the more comfortable you are, the more sympathetic you might be, and that's the goal. We want to treat patients with HIV just the same as we would treat any other patient. And she's given me her PowerPoint to share with you, and I've also then created the assignment based on her PowerPoint, which emphasizes some of those points to make you feel more comfortable in treatment. Also, this is first class of MedComp 2, and I don't want to take a lot of time going over everything. I think you pretty much understand how my class runs. If you look at the breakdown of percentages between the syllabus and Canvas, you'll have a good idea of what that is. I believe that Farm's sectional exams and my sectional exams are on different dates this quarter. Is that correct? Yeah. Because I talked to him over vacation and said, I would like these dates. What dates are yours? So he said he would not do it on the same day. Okay, that's really good. So we'll have 2 sectional exams again. We're going to do some in-class case studies with your teams, so that you really get comfortable asking the right questions, coming up with the proper treatment modifications, more like what you will do upstairs. You also will be practicing every week here in clinic upstairs. So we can talk about anything else about the actual course next week, but I think you're pretty familiar. You can look at through the syllabus. There's really not many changes other than the breakdown of percentages. So you can look at that. And also, I just want to encourage each of you this quarter. I know you're a little overwhelmed right now with oral path. I just want to tell you that I know it's scary, I know it's overwhelming, but Dr. Richards also is 100% on your side. I highly encourage you, if you struggle at all, to go talk to her. She really wants you to be successful. I know her well, and she will do anything to help you be successful in this class. So if you're struggling, if you have 1 or 2 quizzes that don't go well, go talk to her right away. She can partner you with a senior that really understood the concepts well. There's a lot of things she's willing to do. So just know, I know it's a little scary, intimidating that first week, know that she is totally 100% on your side too. So I encourage you to do that. Same with any class. As usual, come see me if you ever need anything. I'm more than happy to meet with you. So I just wanted to start with prayer this morning and see if anybody had any requests or anything great that happened over spring break that you want to share. Yeah, just hold up your hand. Go like this. I want to share. And it's beautiful. You did well. Yes.
Over the break, we found out my grandma had lung cancer, and she had her first chemotherapy this week, and it's affecting her a lot.
Yeah. Oh, I'm sorry to hear that. Thank you for sharing them. I know we had a lot of things we were praying for last quarter that were some pretty heavy-duty things. And I continue to pray for you, especially the people who have lost family members or friends or that are family, that they lost as well. So, anybody else? Rachel?
There's been, at the school I used to go to, Union, there's been like a couple student deaths of like people I knew or like interacted with. And it's like really touched a lot of my classmates, so just pray for
It just happened recently.
over the past like month, I mean 2 people passed away in
Wow. Wow.
I know it's kind of like crazy. So
Yeah, that's
really
really
pray for everybody surrounding that.
My grandma passed away on Tuesday, so just stay with my mom.
Yes.
One of my childhood friends passed away a couple of weeks ago, and she left 2 kids behind.
She left what?
2 kids behind. She had 2 kids. So
That's really hard. Yeah, over break, there's a couple of people I heard of too. So it's just, it seems like there's a lot of loss surrounding us. And I had to remember the other day, my devotional talked about being thankful during all times. And sometimes we get lost in the tragedies. And I'm not saying that we shouldn't feel them too. And we did just have to go through too, or we could and look for the little things during the day that are blessings. And so I really pray that your class is a blessing to each other and that you support each other during this time and during these sad times. You hear these prayer requests that are really hard and heavy, and losing anybody in the family or a friend is very difficult. So I just encourage you to reach out to your classmates that have shared and willing to share, and also not just during hard times, but just during the quarter. The more you support each other, the easier this quarter will be for you. So I encourage you to stick together and help each other out. If somebody gets one class really well, share with the rest. If somebody else gets another class, and share with each other. I think that is so helpful. And in the end, you're such close friends that you stay in touch forever. That's my classmates. We still are in touch after all these years. So, okay, anybody else? Okay, let's pray. Our loving Heavenly Father, thank you so much for each one of these students. Thank you that they had a safe break and hopefully got a lot of rest. And I pray for each one of them as they have now come back and started a busy spring quarter. Please be with each one of them, give them strength, give them health, give them sleep, and give them the ability and the compassion to support each other and lift each other up and help each other in times of need. And we just are grateful for a school that we can come to, that we can pray and lift each other up and our own concerns to you. And I know every student in this classroom has things on their plate that may make things a little more difficult. And so I pray for each one of those. You know what those are. And I pray for all the prayer requests today that you heard, where both Aileen has lost somebody, Jessica's dealing with her grandma being sick. I pray that you put your healing hands upon her and help her through the therapy right now. Be with Megan and her family as they deal with this loss. Comfort them, wrap your arms around them, and help them to feel your presence. And the same with Rachel's classmates from Union and the terrible loss of young adults, and just help them as they sort through the things that don't make sense in this life. And just pray for every student here, and guide and direct us. Thank you for Dr. Cho today to help us understand people who are infected with HIV and even the emotional things that they may go through. And so we thank you for hearing our prayer. We give this day, we give this quarter, I give this class to you, Jesus. We pray in your name. Amen. Okay. She's going to use Pull Everywhere, so you'll have to connect to hers. I'm not sure if that happens when the first question comes up.
It's coming up very soon,
So
yes.
you can just be ready for that. They do have an assignment that follows. It's kind of like lecture notes. So if they're typing and they're on their computer, that means they're only looking at your PowerPoint and following this great lecture, okay? And they're good at asking questions. She would love it if you asked me questions. So you're welcome.
Is she going to be using yours and Paul's?
No, it won't be mine. So when her first question comes up, there should be a little way to log into her Pull Everywhere. Okay. Thank you.
Thank you. Good morning. Can you hear me okay? Yes. Is this working at all?
No.
That's weird. Does it have to be just like this? I don't know if it'll help. Okay. I'll still leave it on. See if it's capturing anything happening in the vocal cords here. So good morning. My name is Euni Cho, and for those of you who don't know me, first of all, for the reason that I get to do this lecture is because I'm the new program director of the HIV and Dentistry program here. It is a government-funded grant that we've had at the school for over 16 years. I've been an instructor in the grant for the last 8 years, and our program director retired and handed this off to me. And so it's been a real privilege to sort of take it to the next level. And what I miss is being in the classroom. And as Mrs. Hayton was asking, though it's pretty rare now that I can get into the classroom, but you're going to meet our incredible instructors when you do come to the rotation. My other day job is I'm an assistant dean here for educational quality and outcomes. I graduated from dental school here in 1993, and I've been an assistant professor all of this time. I wanted to go over some objectives before we started the poll. First of all, we're going to do just a pre-test of knowledge, and you'll see a post-test after you do our rotation. I was the mentor for one of the hygiene student research groups this past year. And one of the things that we did was we took all the pre and post surveys that we've done over the years, because everybody does come through my program. And so we looked at the data from dentistry, international dentistry, and hygiene. The interesting thing is after the rotation, everybody's knowledge base and skills base is very similar. It's not significantly statistically different. So that's really nice to know that the program, after the program, you guys will all be on the same plane in terms of knowledge and skills about HIV and AIDS. But what was really telling and significant about the study was that the pre-knowledge, the pre-test, was very different. And so the dental and the international dental students came in with a higher knowledge and skill into the rotation versus the hygiene students. So of course you want to ask the question, why? Is it just because you come from the undergrad background? What did they get in their undergraduate 4 years that prepared them? And what we have figured out that it had to do with a pre-lecture just like this that the dental students get every spring before they come to our rotation. And so we're going to embed one of these lectures for the hygiene program before you come to the lecture. And then we're going to see how you do on the pre-survey, post-survey type thing. Okay, so, but since it's our first year, I'm going to go ahead and do the pre-test of knowledge today, and then you'll do the post-test after the rotation. Today is just an introduction to HIV and AIDS. And the reason why is because there's so much information. There's no way to get it all in. And you'll end up with probably a total of 10 hours of HIV and AIDS curriculum that's really focused. And even at that, there's really no way to capture everything. Like, we'll spend very little time talking about medications. They change regularly. Almost every year, there is a new great drug coming out. And before 1995, patients who were positive for HIV could hold all of their HIV medications in their hand like this. There was an average of about 30 pills that they took twice a day. And in 1995, we started to see the emergence of what they at the time called HAART, H-A-A-R-T, which is highly activated antiretroviral T therapy. And that went to the 1, 2, 3 pill regimen. Of course, it was very life-changing, as you can imagine. And since then, it has improved dramatically where they're able to get some of the major key ingredients into 1 pill once a day. So this is just an introduction. And I was going to let you know that when I started teaching in the course, I turned on a notification system on 2 of the top HIV information websites, one run by the government and one run by a private entity. And my phone was going off every day. And I just could not keep up, read the literature, with all of the changes. And so what we've done in our grant is we attend 1 to 2 annual updates on HIV and AIDS because there's just no way to keep up with the research going on all over the world. And while I will mostly focus on U.S. epidemiology and numbers, the worldwide epidemic of HIV and AIDS is hugely significant. They don't see the same positive outcomes that we've seen here. The research, there's great research going on outside of the U.S. On this. And so some of the advancements that we talk about is research done internationally. Okay, so we're going to spend some time on risk assessment, and we're going to spend a lot of time on PEP. Will you guys just give me just a second? I'll keep talking, and I'm going to set up my survey. But I had somebody come down and open up the PowerPoint for me, and I see he's got an old version. So my bad for not checking that. So we'll start the survey in just a little bit. Miss Hayton and I were just talking, oh, don't you just hate technology that doesn't work? And I needed some help this morning. Okay, so let me see if I got the right one now. Let's do the poll. So for me, if you're going to do it on your phone, it's, you're going to go to 22333.
Is that your username?
That's the text you're going to, if you're going to use your phone and do text, go to 22333 and then you're going to put my name. Here we go. Let me project. EUNICHO 176.
1137.
They haven't texted in.
Oh, you guys just use website or the apps? Okay, so in the app, it's Euni Cho 176.
And Uni's from EUN.
NICHO. And I've got this up. Yeah, 176. But then, of course, view. There we go. When I did that. Yeah. I'm telling you. I think I got it now.
Just go here. Okay.
Okay. Let me expand it. Okay. Okay. Is that a good start? Thank you. This is the first question. What is the first word that comes to mind when you hear the word AIDS? Can you text in one word? Are we looking for about 30 some results? 38? 41. Thank you. Okay. Oh, very nice. If you don't mind, why did someone write Johnson? Thank you. Okay, very good. All right, here is your first question. I plan to practice dentistry in the state of Washington at some point in my career. Activate, thanks guys. This is going to be a joint effort, I can see. The reason I asked this question is because if you go to get licensure in the state of Washington, they're going to ask you to provide evidence that you've had 8 hours of HIV and AIDS training. So we provide a letter saying that has been accomplished. There's a module on Canvas, and if it hasn't shown up yet, we'll get that on there. And then you just send us the score. You can probably pass the 10 questions just from this lecture. You will be able to, but all the review materials on there. And then take the test and send us the screenshot of the results, and then we'll issue a school letter saying that you've had your training. Okay? I plan to treat HIV and AIDS patients in my practice. Okay, thank you. What is your general knowledge about HIV? Thank you. There is a cure for HIV. How confident are you in managing an occupational percutaneous exposure? Okay. All right, let's get to the CDC definition of AIDS. They include all of the following except. And CDC stands for the Center for Disease Control. They've added another word to it, but they didn't want to change the acronym. So it's actually the Center for Disease Control and Prevention. Still stated as CDC. So I'm watching the counter before I show results, because then I lose my counter. Let me see the results. Show results. There we go. Okay. What percentage of HIV positive people in the U.S. do not know they are positive for the infection? So they're infected, but they're walking around not knowing that they're infected. What percentage of the U.S. that are infected don't know? What are facts about getting tested for HIV? And I'm asking for the exclusion. So which one of these are not a true fact about getting tested? HIV is transmissible by all of the following except, and let me tell you what those are. The first one is saliva, urine, tears, and perinatal in utero. HIV is transmissible by all of the following except. Can you take out the word except? I just see that I flipped it. HIV is transmissible by all of the following. And there's only one correct answer. And which one? Can't change it? My bad. Okay, sorry you guys. Yeah, those of you who hadn't voted yet, it is perinatal. We'll get to that. Sorry. All right. Aerosol-producing devices such as handpieces and cavitrons are contraindicated for use on HIV-positive patients. True or false? Show results. Here we go. It is standard of care that all HIV positive patients should receive antibiotic pre-med prior to invasive dental treatment. It is illegal to refuse to treat a HIV positive patient just based on their HIV status. Do we use universal or standard precautions when treating an HIV positive patient? How about statements about viral load? One of these is not true for HIV positive patients. Okay, let's talk about PEP. PEP is post-exposure prophylaxis. All right. Thank you so much for this information and data. Let's go back to this. There we go. Okay. We're going to talk a little bit about PEP and then your rotation. We're going to talk about a case study if we have time. Let's get rid of this. Oh, this is really something new that they're able to do this colored transmission electron micrograph of the HIV virus. And you see it that it's the green, and they're attaching to a white blood cell in orange. And you can just really get the sense that it's taking over. And the attachment is key, and then being able to replicate after that. So, you want to know that because then you understand where the scientists or the researchers are going to focus for a cure. If you know that HIV can do nothing until it attaches, okay, how do we prevent it from attaching? And then it can't grow. It might attach, but it can't grow unless it can replicate its RNA. And so maybe that's the point that we focus on research. So there are today 2 known patients who've been cured, the word cured, of HIV. So when we ask, is there a cure for HIV? Both answers are correct. We have 2 that they are categorized as cured. It's very specific. It's a very specific situation in which a cure can happen. This is the first one. It was in 2007, and he identified himself. His name is Tim Brown. He's an American that lived in Berlin at the time. He was HIV positive there, contracted the infection in Berlin, and then got a cancer. He got a form of leukemia. And when you take pathology, you're going to find out that those 2 go hand in hand very often. So at our clinic, that's an HIV clinic, we have quite a few patients that are also dealing with cancer. And why do you think those two go hand in hand? Immunocompromised, yeah. So he had a bone marrow transplant, and I think it's important to at least see this protein, what it looks like in name, CCR5 with the mutation on 32. He had a bone marrow transplant from somebody who was a match for him, except that they had this mutation that they did not believe would reduce the efficiency of the bone marrow transplant for the cancer, never expecting anything to happen with the HIV. And now, since 2007, there are no traces of the HIV virus in him that are detectable. So he's a cure. That's the protein, CCR5 with the mutation on 32. So as you can imagine, since 2007, all over the world, they start doing research on HIV positive patients who also have cancer. Who are the donors of this bone marrow transplant? They're of European descent. A few are Asian, but the vast majority, and there's only a handful living in the world with this mutation. I mean, I think I just kept thinking about what a social responsibility. How much bone marrow can they give if they feel that this is the one that's not only going to cure cancer, but HIV as well? And so I believe I wrote a note, 150? There's under 200 donors with this mutation on this protein. So what happens is the HIV virus can still attach, but it can't replicate. So just this year, in March, if you followed the news, there was a second patient that they believe has been cured. He has asked to remain anonymous. He lives in London. He was HIV positive and developed Hodgkin's lymphoma, also had a bone marrow transplant with this mutation and was cured of both. With him, they're watching him closely because he's under 1 year cured. So they want to see more results like Tim Brown that, is 10 years or more. There's several people in the study. There's about 38 people in this study. And the other one is the Dusseldorf patient. He lives in Dusseldorf. He's remained anonymous. He's in the same study, has had the same cancer, and is positive for HIV and has had the mutation. And he's only about 1 or 2 months out since they have not been able to see the HIV virus in him. So, yes, question.
So are they only doing it to patients who have cancer as well, or does it matter?
Good question. In the study of 38, there's 5 patients who are HIV positive and don't have cancer. So what happened with the Berlin patient, they took it to the next level where they found more HIV positive patients with cancer. There's a lot of them. Which cancers? They tried to limit them to the ones that were very similar to the first patient. And then when they saw positive results, like with the London patient, then they were able to take it to the next level and accept patients who were just HIV positive. Now, why are they going so slow in this process of who they let into this study? We just showed the Berlin patient cured of HIV. Why didn't they just start bringing more just plain or sole HIV positive patients into the study? Why did they say we got to look for patients that have both HIV and the same similar type of cancer?
That's the only time it worked.
We need to limit what the difference is so they can narrow in what exactly
That's right.
is making a difference.
It's the only time it has worked. There's a lot of bone marrow transplants for cancer that don't work. But that is exactly the right answer, and that's how the research world goes. You don't just say, oh, let's just try it. Let's use it on all the HIV patients. What's the harm? It's not going to hurt them. But as you caught early on, there's not that many patients that have the mutation. You're very limited, and so it's so valuable. You cannot just throw a dart in the dark and hope that it works, and worked for somebody, didn't work for another person. Gee, wonder why it worked for this one and not this one, and then work backwards and try to figure that out. That's not the way research, science, the development of drugs, that's not the way it works. And it's very costly, as you can imagine, to run a study like this. But again, very, very promising. And now that I go to the meetings, the talk of a cure is a lot more widespread. The first few people who talked about a cure, they were pretty much laughed at. So this was one of the questions. And you have to be HIV positive, of course, but we look at the CD4 count when we do the definition of AIDS. The reason is CD4, which is actually a combination of CD4 and T cells. In science and in health, that's an indicator of how strong your immune system is. So let's just go right to the CD4s. In an HIV positive patient, then the CD4 count starts to go down because the HIV virus cells love to attack the immune system. So they're going and attacking the immune cells. And so you're going to see this count going down while the HIV viral count goes up. Yep, like this. And so when you get less than 200 cells per microliter, then they've put you in the definition of AIDS. You can be HIV positive but not have AIDS. Did you know that? They're different. If you got a patient that says I have AIDS, they're just positive. That goes that way, but not the other direction. So if someone says I'm HIV positive, please do not just assume they have AIDS. And it's very interesting why some people care about that and why some don't. HIV positive to some people sounds like a medical condition, and they feel that there's less stigma, and so they'll say that they're HIV positive. They don't want to say that they have AIDS if they don't have it, because AIDS carries a lot of stigma with it. So, but there's the flip side on why somebody would want to dip so low in their health that they get the AIDS definition or diagnosis on their health records. Does anybody have any idea why someone would let their CD4 counts go down just below 200 and then they get diagnosed with AIDS? Yep. So the types of benefits and support and resources that you can get for having AIDS increases dramatically. And so it's a dangerous game, and at the same time, you kind of wonder what's wrong in the way that the system is, that somebody would actually want to play that very dangerous game. The other thing is that we have seen people come in with less than 200 CD4 counts, and the medication right now is so effective for so many that we can probably get their CD4 counts up. But now they've been diagnosed, they get their resources, all of that. And obviously a lot of that happens unintentionally. And then we can get their viral load down. So this is for interesting discussion as we talk about bioethics and things like that. I just taught the HIV course in the D1's bioethics course, and we presented tons of cases and just talked about it among the students, and it was very interesting. If they don't know that they're positive and they just let it progress, it's about a 10-year time before they naturally go into AIDS. People do not become HIV positive. They don't seroconvert to positive and then just remain healthy. It's never been seen to do that. It is a degenerative, progressing, declining disease. And in about 10 years, we will start to see that the CD4s will drop, and that could be a very, very healthy patient, but it's still going to drop. Viral loads are going to go up, and there's a very good chance that we're going to see an AIDS indicating condition So these opportunistic infections that we're going to talk about. So regardless of their CD4 count, if they get one of the AIDS indicating conditions, then they fall under the category of AIDS. Any questions on that? Yes.
So the HIV is lower than 200, but AIDS would be higher?
Flip it.
Okay.
Yeah. Yeah. So HIV positive is just being, there's tests for that, and then you're positive. How do you get into the category of AIDS? And that's why the CDC had to define it, because there's a lot of ramifications for being in the category of AIDS. You're very sick, first of all. So they're definitely going to have to direct a lot more resources to support this person. Any other questions? Yes.
This may be silly, but how do you get HIV?
Okay.
How do you be HIV positive?
Yeah, let's talk about that. You guys had one of the questions was, how is it transmissible? And the right answer is a mother can pass it to the baby in utero. More commonly, mothers will pass it to their babies during the birthing process. And why do you think that is?
The blood from
What about the blood? The what?
the cross-contamination of the blood of infected mom to the baby.
Okay, very close, and you may be actually saying the right thing. Just the physical trauma of giving birth can tear tissue, and it has to pass with tearing. You have to have an exposure of one blood to the other. So that happens. That's why in breastfeeding we've seen it. Because those of you who are mothers and have breastfed, we know that the babies can suckle so hard that they can tear the breast tissue. And so we've seen the mother transfer it through breastfeeding when she didn't even transfer it in utero or at birth. A lot less now, because we know so much about it, and there's so much we can do to help patients prevent the transmission. And I told you that the CD4 count really is a T cell combination, and it equals immune function for healthcare. And even though it says we'd like to see greater than 600, I think, the target is you want to see about 1,600 as a healthy immune function. And you can see as it declines, you can see exactly what's happening. So if you see an opportunistic infection, the OI right here on the third one, most likely your CD4s are going to be in that range. So you're the oral health care professional. You go look in the mouth. They put that on their health history that they don't have HIV, that they don't have any other medical conditions. You look in the mouth and you see an opportunistic infection. That's an indicator for HIV. There's a good chance that that's their CD4 count when they go to see the doctor, or lower, because they may have had it for a while and not known it. And very much so, you'll see it in our clinic over and over again, where we're the first ones to see one of the AIDS defining situations, because many of them are in the mouth. And it's, when's the last time your primary care doctor had you open wide and looked past the whole mouth down your throat? Because that's they go straight down the throat. And look at your tonsils and adenoids, and they miss the whole mouth. They don't pull back the lip. They don't lift your tongue. Look under the tongue. Look on your cheeks. So you're going to be, very often, you may be the first one, and we can talk a little bit more about that. Okay, here's our USA epidemiology. This is really important. For those of you who don't know, AIDS was first recognized in 1981. They didn't know what it was called. They didn't know what the virus was. They didn't even know it was a virus. It was affecting a very specific population of people, and it explains, and it's very much understood, that because it was a small group of gay men in San Francisco and Los Angeles, that all they did was treat the symptoms and did not put a lot of haste or importance on trying to figure out the cause. Of course, it started because once these things go to the Department of Public Health, a lot of balls get rolling. But I would say that if a child came up with HIV. A little group of children came up with HIV. I guarantee you that there would be a swarming trying to figure out, are they at the same daycare? Are they related? Are they friends? Do they drink the same milk? You know, but there was a lack of haste back in 1981, and you can see that it took 2 years to even find the etiologic organism, which then was identified as HIV. They called it something else first, but yes, it was HIV. And by then we had 800 deaths, and you can just see the cascading effect that has happened. Testing finally became available in 85. At that time, 10,000 cases of people living with HIV and AIDS was counted. And that acronym PLWHA is very common now. So you don't want to call them all patients anymore, because some of them don't get care, and we'll talk about that on the next slide. And so you'll see a lot of really good terminology coming out of this whole epidemic that really applies to our work. So people living with HIV and AIDS, PLWHA. 100,000 cases in 89. This is just in the U.S. and of course across the world. This number is exponential. 500,000 cases in 95. But then HAART gets introduced. That highly activated antiretroviral therapy gets introduced, which is the 2 to 3 to 4 pills. And not only are they effective, but life-changing for our patients. And then we see the death rate go down. So when the death rate goes down, but every year you're having sort of either the same or increasing number of cases being diagnosed, then incidence of death may go down, but prevalence of the disease goes up in the U.S. You get the difference? So you're like, great, less people are dying. So you've got the death rate lowered. They're living longer, although at that time, not nearly the lifespan that other males and females were experiencing in the U.S., but it was improving. But then as people are living longer and they're still getting infected at the same rate, the amount of people living with HIV and AIDS in the U.S. is now starting to go up because they're living. When they were dying, the people in the U.S. with HIV and AIDS was about steady, dying and getting infected at the same rate. So what that does is now you got to start building a system to take care of people living with HIV and AIDS. How much money are we talking? How much research are we talking? Do we expand the Department of Public Health? Do we expand doctors who will see HIV patients? And then you still have to tackle this other issue that is on this care continuum. Many people call it the HIV cascade. And this is important because you can see on the far your left that there's about 1.2 million people in the U.S. that are living with HIV and AIDS. And then when you go down to the next bar, it means 87% of the 1.2 million. This bar means 75% of the about 90,000 people, so forth. And that's why they call it a cascade. So these percentages are not talking about the first red bar. It's actually every next bar is talking about just the one preceding it. So I'm going to give you a minute to look at this. This is the latest one from 2017. And I want to know what you think is the most alarming thing about the cascade.
I have a quick question.
Yeah.
You had said that the PowerPoint was not updated. I'm wondering if ours online isn't, because it just has different numbers.
Did I give you the
We have
old
one
one?
that shows like 25%.
On the first couple slides.
Yeah.
We do have the
Old one.
Sorry. Okay.
I'll get it to you. That's why.
They didn't have about the two gentlemen who making the shirt too. So is
And
that
we had talked about how I was adding that.
okay?
Sorry, you guys.
50,000.
Will you
Well,
guys
I just
just...
wanted to double check that.
Thank you so much for clearing that up. I'm gonna say the rookie mistake, but then next year I'll have no excuse. So, yes.
Is the worksheet that we were like online, the Zoom thing, does that go to the new one or the old? It goes to the.
It will go. I'm going to repost
Okay.
because I want the most updated information.
Thank you, guys.
I don't think there's that many. I mean, there's some things that have changed.
There's, and I'll point them out. How about that? The cascade you have on there is, I think, from 2013, and so this is 17. But look at the cascade in terms of how one number affects the other, and tell me what is the most disturbing number on this cascade for you? Yes.
Infected that don't.
Okay, they're infected, but only this much is diagnosed, right? And so it is a difference of what percentage? 13%, so that was the answer on the thing. 13% of people who are infected do not know that they're infected. Do you know, I've been teaching this class for almost 8 years, and that number has always been 20 to 25% do not know. And this is a big change for us that work with HIV patients, that only 13% do not know. So what is that telling us? What are we doing right?
Yeah. Research and testing.
Yes.
Screening.
Testing, screenings, talking about it, putting a mobile unit over where like a risk population may be, and say free testing, in this door, out this door kind of thing, all kinds of things that we can do to make it conducive for them. Because let me tell you, we got to get them diagnosed so that we can get them taking meds, so that we can keep them in care and get their viral load undetectable. Because yes, when your viral load is undetectable, the chance of spreading it to the next person is very, very low. Many believe no risk. I get nervous saying it because we were never allowed to say that before. You first?
So this might be like a very uneducated question, but so obviously you were saying in the beginning that HIV can be associated with the homosexual group because when it was first found out, it was that group that had a spotlight on
Yes.
it. But for the mother to get it, to give it to the baby, how is the mother getting it? Does she get it from her mom?
Very good. Okay, good question. So, and I don't think I have it in here, but it's interesting to know that today, of all of the people living with HIV and AIDS, 75% are still men who have sex with men. And as you can see, that's another medical acronym for a terminology, because we no longer say gay because they may not be gay. They may have other ways that they identify themselves, and we want to respect that. And so in medical terminology, we get right down to the act that is transmissing. Do you get it? So MSM, men who have sex with men, that's the 75%. Who are the other 25%? The vast majority of them are PWID, people who inject drugs. Yeah, so they're a big majority. So did the mother contract the HIV virus because she was a IV drug user? Did she have sex, unprotected sex with somebody who was positive from these other methods? Did she get it from her mother in utero? So you see, once you understand the routes of transmission, then you can sort of figure out, how they got it, the possible ways. Okay, so the 13%, that's true. What didn't you like?
What's the difference? What's the difference between retained in HIV care and linked to HIV care?
Okay, so we believe there's this many people walking around positive, only they know, out of that group. Only this many got linked to care.
They got diagnosed.
Like they know that they have it and they were able to get medication to treat it.
Yeah, so really quick, before the link to care only means that maybe they did a screening at one of these mobile vans like I talked about, and only 70, and they found out there in the mobile van, and then only 75% of them got actual linked to a doctor who specializes in HIV care, because some of them walk out with this fact, keep it a secret for months and years, and then they go, where do I go? And they don't know where to turn to get linked to care. So there's linked, then out of all those that finally do get linked somehow, only 57 stay in care. And why is that?
Because the
They don't
level.
They want to keep it secret.
Okay, so it's a behavioral, emotional, psychological reason for many of them. Somebody brought up cost. When you get diagnosed with HIV, being HIV positive and you get linked to care, in terms of medical care, it's covered. So usually that's not the barrier for most of them. If they understand that it's covered, then it's not a barrier. Because an insurance company would be really irresponsible to say, covering HIV care is so expensive, it's a non-covered benefit. Why? Because as soon as someone's HIV positive, you want to get them into care so that they don't transmit the disease anymore. So to not cover it is very irresponsible. It is covered. And if you don't have private insurance, there are governmental funds that cover it. I work for the Ryan White grant in this job, and Ryan White gives us money to pay for dental care if your insurance, dental insurance, doesn't cover certain services. The bigger part of Ryan White is for medical care, because somebody just doesn't qualify for some kind of coverage. Ryan White will kick in. So there are funds. So it's usually not a money issue for medical care. A lot of times it is they cannot get over how their life will change, and many give up, many go up and down. And you're going to see this in our clinic all the time. And this is why we look at viral load, and we're going to talk about it in just a little bit, because the viral load actually helps us determine, are they staying on their meds? How are they so psychologically, because we're allowed to ask about that. Maybe the med just isn't working anymore. They say, doctor, I take it. I take my meds every day, but I'm starting to, let's say you see an infection, candidiasis or something in their mouth. So maybe their meds aren't working, or they've developed a resistance. So there's a lot of reasons, a lot of questions you can ask just from what you see in the mouth for someone that you truly believe are keeping up with their medication and regimens. Okay, but I love this number. When they're retained in care and they take their medication, see their doctor, do their labs regularly, they can get to undetectable viral load. How do you like this number? And sometimes you show the patients this, in their terms, and that can really motivate them. Because I think that this is the part that they don't really believe can happen. So you've seen it. This is the new numbers from 2017. So once they get retained in care, we can get them to an undetectable viral load. Yes?
Just to clarify how to read the graph, are all of, so after 87, 75, 57, is that being compared to the 100% of it? So 55% of the set 57%?
Yeah.
So like basically half of the 57% who are retained? Or is it?
Oh, I see.
Like just the cascading.
Yeah, this thing actually, these last two,
Are they like?
do you see how that they're the same bar?
Yeah.
Yeah.
So it's not 55% of the 57%. It's like, what's the base?
Okay.
Kinda, yeah.
All right.
That one's
So like.
Okay, nationally, thank you so much. I actually have to clear that up. Okay, it's a cascade, so it's only the one before.
Okay.
So I got overly excited and saying that it's almost 100% of people retained in care undetectable. It's half of them.
That's still good.
It's excellent because we haven't had that. And what's interesting, that those in the Ryan White program, our program, those numbers are even better. And I'll get to it. Thank you so much for bringing that up. I got very excited over that one. Here's the USA trends. So in 1981, less than 1% were women. And now they're about 25%. Steady, even now. I like to use the posters that the CDC and HIV Dent and other very known, respected, vetted resources use. This was a campaign that the CDC put out somewhere around 2002, right? So he's lived with it since '04. So this must have come out a little after. But I just like to use some of the same posters that they've used in their promotions. And then ethnic trends. Of all the women who are positive, 80% are minorities. Men, 70% are minorities. And the age predilection, the only group that's on the rise is 25 to 44. But I think it makes a lot of sense, you know. So who needs to get tested starting at age 13? And this is such a tough topic, but this is what the CDC recommends. Will you be the one that says, you're 13, you should be getting HIV tested? That's going to be for you to decide. And there's going to be many times today and when you do the rotation that we're going to say, you decide for yourself. What's great about talking about it first of all, there's all of us and we can talk it through and talk about different scenarios so you can develop your own decision about it, professional decision. But also once you've done that process, when it really happens, like when you get a needle stick, it's sort of easier to make that the educated and evidence-based decision because you're going to be pretty emotional about it. I think that's what we've seen over and over. So, and then I've had needle sticks as well. So, but this is what the CDC guideline is. Of course, it's the pediatricians and the medical doctors that will do a routine medical care and then recommend this or let them know that the CD recommends this and the parent gets to decide. Although, as you know, in age 13, unless the child gives proxy to the parent, a 13-year-old can make their own decision. And so the medical provider would probably bring that up. A scenario of how we can contribute to help with this. And obviously they're saying 13 because they've seen under 13 coming up positive. Yeah. So how do we help with this? If you hear about any risky behavior, if you see an opportunistic infection on a child, which is rare, and it would be serious, then what does that conversation look like? So you're just with the child, you are getting ready to start their child prophy, right? Should be nice and easy and quick, and you see oral candidiasis. What's the first thing you say?
Well,
Huh? Yes, you're going to talk nicely. So
we just ask them like what their home life is like.
Are they sexually active?
What are their symptoms?
What if they don't know they're sexually active because something happened and it's not, they don't want to talk about it? I don't know, that's so
good point and good question. Did you say you would ask, or as a possible, you said you would ask what?
If they knew if they had it.
If they knew they had what?
HIV.
Okay.
I mean, that's like,
okay.
Not to 13-year-old. Have you had them checked out?
Have you had what checked out?
Yeah, that's a good one. Yeah, have you had that checked out or did you ask your doctor about it?
Okay.
What would you say?
We don't see children over at SACS, and in my own private practice, I did not ever see a child with an opportunistic infection that was AIDS defining. But you want to be prepared. You know, you don't want to be like this, and then that child is in your chair, and you bring up so many interesting scenarios of you know that everything's adding up, but can you make a diagnosis with the opportunistic infection in the mouth? Why? Because what's the other part of the definition? They also have to be.
The viral count.
They actually have to be HIV positive, and you don't know that. So just because they have an AIDS-defining opportunistic infection, you don't know that they're positive, so you can't say that they have HIV or AIDS. So how does that, what is that conversation like?
Is there any other symptoms? Was it the fever with HIV or no?
Okay,
I
so,
don't remember.
so that is a symptom of early onset HIV infection. So you ask, what would I do? And I've never been in this situation. But here are the facts that I know. And then I would like you to formulate your own, what would you say, thought statement in your mind. I already know that I don't have a confirmatory test for HIV. So we cannot say that. I will tell you that much. We cannot say that they're positive. It looks like you're positive. It could be AIDS. We can't say any of those things. Yes?
Can we just tell them how the doctor check it out?
Very good. Very good. And so this is your 13-year-old. And maybe this family, I know I did not know until recently that my 13-year-old would have to give me proxy. I had to take him down to the 101 building on Redlands Boulevard, and with each of my kids, they met with each of my kids and explained what it would mean to give your parent proxy on your healthcare record, and my child had to sign off on it, and then they showed up on my app. So prior to that, I have no idea what was said in that room. I have no idea. Yep. So now you've got this 13-year-old in your dental chair. We don't have the proxy in place in dentistry unless they have one of these medical insurance that also have dental with it. Then the proxy is all encompassing. So if it's one of those HMOs that have dentistry, like Kaiser's getting dentistry, everyone's getting dentistry added to their insurance plans, then for me, they're still a minor. To us, there's the medical rights kind of view of them. There is what age they are, and they're a minor. So maybe one of your first considerations is to bring the parent in the room.
Oh my God.
I know. So you ask the question. I know what you're going to ask is, what if they don't want the parent in the room, and now you...
Parents want the reason why they have the HIV.
Yeah.
I have a question about
Sorry. Have you met another physician or dentist that has been in this situation and what they've done?
Of course, physicians. We network with a lot of physicians, and I'll show you some of that collaboration a little later on the PowerPoint. Dentists know, and in fact, very few dentists know about HIV. When I am able to give this lecture to dentists for continuing education credit, and we do a pre-survey, almost this exact same pre-survey, their pre-knowledge is very low. Because maybe they went to a dental school where they didn't have this curriculum, or maybe they came here before the curriculum was started here, but all they know is what's in the news, sort of. So, you're going to get a lot more than my classmates and I got in HIV and the management of a HIV patient. One more question?
I'm sorry, Hannah was first.
Okay, go ahead, Hannah.
So kind of back to what Sunshine was asking, we're talking about a 13-year-old, but what if they're like a smaller pediatric patient where if it is indicative that they have AIDS and obviously it's sexual abuse? And
Well, not obviously, because it could be drug abuse, it could be through the utero, so...
Well,
Sorry.
Anyways, if it, in our scope of like mandatory reporting or something like that, you could refer them to a physician, but what is making sure that they actually get to a physician in time?
Can we follow up with the physician?
First of all, is someone going to respond to Hannah's comment?
I'm wondering if can she follow up with the physician?
Can who?
The hygienist or the dentist follow up with the physician if that child went to the doctor?
So if you're asking me, can a dental professional do that? The answer is yes. Okay.
I was doing some pre-HIV reading, and it said if we're exposed to like cut in any instance, depending, knowing if they have HIV or not. If we see oral devices in a pediatric patient, couldn't we just give them a new test called OraQuick Advance HIV antibody test?
Okay, that's in my PowerPoint. And so you asked the question, can't we just give the OraQuick to who?
The kid, instead, or if we were going to refer them to their physician, possibly follow up, or just to avoid all of that, do it ourselves?
Do it ourselves. Okay. Let me answer two questions. First of all, can you have OraQuick in the dental office and administer it to your patient? The answer is yes. Have I ever done that with all my knowledge of HIV and AIDS? No. Because one of the things that if you're the healthcare provider that handed the kit over to the child and the parent, they did the kit in your office, even if they come up negative, there's a certain amount of counseling and education that you have to do, because you obviously offered and administered the test for a reason. You don't just do it for no reason. But if they're positive and they find out in your dental chair, and that's the first time, are you ready to now follow them for the rest of your life? Follow up that they followed up, refer them, but even before any of that, you're going to have to counsel them in your chair. And the depth and breadth of that conversation is very, it's huge.
So just following up on what Hannah was saying, if it was a sexually transmitted or drug abuse type of situation, wouldn't that be considered child abuse, and we would handle it in that manner?
Yes.
If we saw something on their EOI or their EO. So
Yes. The answer to that question is you see that and you know you don't have to prove it. You have to have a reasonable suspicion. You're a mandated reporter. You have to report it. The big question at the front end of it is, how are you going to get to that point where you feel that you have reasonable suspicion? You don't even have to have proof. I get it. But reasonable suspicion, just the appearance of an OI. Okay? I want to keep moving because we're going to address several of these things. But I appreciate the questions very much. You're challenging me even more. It's not transmitted by any of these things. So you can swim in the same swimming pool. You can kiss them because it's not transmitted by saliva. Have you guys ever seen blood in the saliva? Okay. So that's the caveat to that, you know. Blood in the saliva, and we already said it's got to be a full-on exposure, not intact skin, throw it on there and you've got it. You've got to have a cut. They have to have been, given it to you. There has to be that contact. So alone, by saliva itself, with no presence of blood, no, you cannot transmit. Are you 100% sure that it's not there? No. How do we know that? So, but that's why they add closed mouth kissing. So it's on there. HIV is an obligate parasite, so it needs contact. It's not airborne, so that might answer the question about the Cavitron. You can use it. You can use it. You have to use all of your standard precautions, not universal, and then you can use dental products that cause airborne particles because you're protected. But you see how everything has to be there. You don't want to put yourself at risk by not doing all of the steps for that. You had your hand raised?
Yeah, I have a question. If the saliva went into your eye, can that be a possible transmission?
Yep. So the saliva with blood you're asking, right? Because saliva alone doesn't carry HIV. So saliva with blood went into your eye because you didn't have your eye protection on, obviously, you're asking. And the saliva has blood that and the patient is HIV positive, right? So far, so good? So all of these things have to happen. They have to be positive with really, in real life, detectable amounts of HIV in that blood. There has to be enough blood in enough saliva that traveled, didn't touch anything else, and landed right in your eye. That is a splash exposure. And if everything is aligned, absolutely you can transmit.
Doesn't blood dye? Like, I don't know if I'm saying that right, but isn't it not as potent if it's out of the body?
Absolutely, because we said for it to live, it's got to land on something of an exposure. So counter surface doesn't last more than 7 minutes. Hepatitis B lasts days on your counter. HIV about 7 minutes. And what are the ramifications about HIV on your dental counter?
You can spread that infection.
It's there. It's there for 7 minutes. Let's say you've got a pile of dirty instruments. You finally have an hour at the end of the day. You're going to start, the cleaning and the bagging process, and you get poked in a pile of instruments. The instruments were sitting there all day, quite bloody. What are the chances that HIV is alive on there? Yeah. 0 to low. 0 to nil. 7 minutes. Yes.
Would every instance of exposure result in the other person contracting the disease?
No, and we'll talk about that. The question was asked, if you have a true exposure with all of the factors that we've been talking about, that there was HIV, high levels of HIV tainted in the blood, and that you made an exposure of open wound from transmitting it, and all of the planets aligned, will they convert? Will they always convert to HIV? And I'll answer that question in a minute.
I was just going to say in answer to her question, her PowerPoint slide's going to answer that in a little while. What percentage of a mucosal splash is likely to infect you? So that is coming up. Then it's a really low percentage, but like she said, it's popping.
Question in the back?
Does that mean that if those instruments went into the ultrasonic, so would the physicians
So the question is, if that pile of instruments went into the ultrasonic first, before you did the cleaning and bagging and all of that, are the chances less likely? I'm going to go with 0. Finally, I can say 0% chance. If those instruments went into the ultrasonic while you were pulling them out, you got poked, it's going to be 0% chance. It cannot live in water. Okay, all right. Very good questions. But I'm not worried because I can just tell we can fly through some of the slides because we talked so much in depth about many of them. Here's your OraQuick Advance. CLIA waived, meaning you don't need to do it in a lab. It falls under the category by the FDA as a home kit. And so just by the virtue of it being a home kit, it has to be easy and has to give a very, very high percentage rate of the right answer, the right results. And so it's very effective. They tout that it's 99% accurate. And the nice thing is it screens for both HIV 1 and 2. Did you know that there's 2 HIVs? There's 2 HIVs. There's about 13 strains. So I don't want to use me and somebody. Is anyone married to each other in here? Okay. If a man and a woman, both HIV positive, think that they can have unprotected sex, they can give each other their unique strains. And let me tell you, looking for a medication that will attack 2 strains is extremely difficult. So we had a patient that met in our clinic at Saks, got together, had unprotected sex thinking this was
the answer for them, and one of them, not the other, one of them got co-infected with the strain from her boyfriend. And so now she's dealing with trying to find a medication that attacks both. Part of the reason why dentists cannot keep this stuff sometimes is because the shelf life is so short. And you think about the instances when this comes up, even me, I mean, I don't see that I'm going to use one a month, so the shelf life is short, it's expensive, you have to throw it away when it expires, but the results are in 20 minutes. Please be clear, this is only a screening tool. It's like an early pregnancy test. You have to get confirmatory diagnosis. If you yourself use it, you offer it to your staff member, because let's say they're the ones that get the stick. And we talked to the dentists about this, that if you're going to own a practice and one of your hygienists, dental assistants, even a back office person gets a needle stick, or your sterilization tech, you're responsible for being able to support them through this process and getting them into care. Yes?
How long after getting sick or broke can you find the virus?
Okay, so this one, if you got stuck in the office, there's a window that most tests, especially screening tests, there's a window that most tests will not catch that you're positive. So it'll say you're negative, but it's false. So they call it a false negative. And this is the same case. So if you got stick right there and then you take this, it's going to tell you whether you seroconverted or not. Because many things have to happen because your body has to produce the antibody, and this is testing for the beginning of the antibody. So this is the situation that you may use this is, let's say you get stuck by a patient and they say, I don't think I'm positive. Then you might be able to say, would you be willing to do a screening test, because the results of this test may affect whether I start the medication for PEP. Okay? All right. Here's the confirmatory diagnosis now. This is 100% accurate. They're done in labs. They check for both the antibody and the antigen. They can detect the acute infection. So they're saying about 48 hours after infection that this can detect whether you're positive or not. So that's why some of the counseling is, if you engaged in a risky behavior and you find out that the person you were involved with, either through drugs or sex or contact, you find out that they're positive, they disclose to you they're positive, this test is very helpful. You just got to get the doctor's orders and figure out who's going to pay for it. And this will tell you right away. And I wouldn't wait. Okay. We talked a little bit about the stages of infection. This is important as healthcare providers only because, let's say you see an opportunistic infection or you hear about some risky behavior and they tell you they just went through flu-like symptoms that hospitalize them. Usually the hospitalization will catch it, but that's something you may want to probe just a little bit more, see if they've seen the doctor, because a lot of times when people feel flu-like symptoms, they know it's 2 weeks and they just stay at home and they take care of themselves. But if you have other things that are contributing to it, then you have an opportunity to really encourage your patient to go see their physician. Here was a viral load thing. We don't use it to indicate whether you have AIDS. We have a patient at the SAC clinic that his viral load is so high. And obviously he does have AIDS, but you would just never know it walking around. He looks like the healthiest person in the world. Very athletic, works out. And yet the viral load is high, CD4 is low, struggling with the meds and things like that. So it's not just the look of the person, and you're going to learn that over and over again.
in this course, this one, MedComp, about how you're going to do a risk assessment on your patients, and it's for that day. How do they present today, and make a decision about their tolerability of treatment for that was planned for that day. The viral load is helpful because I can tell the disease is progressing even though they're taking meds. So either it's not working for them, it was the wrong one, or they've developed some kind of resistance. And here's the antiretroviral treatment. In 1995, they called it HART, but because now we know they're all highly activated, they dropped the H and the A, and they call it ART shortly thereafter. So we call it ART, antiretroviral therapy. And basically, you want the viral load to become undetectable. Do you know that when I started teaching the course, there was this whole risk assessment that medical doctors would do to decide whether the patient should start ART? So they test positive, they do lab work, they get their numbers, and then they do this whole algorithm to figure out whether the patient should start HIV medications. That was even true up to a year ago. And the reason why is because the side effects are just so potent and toxic. So they wanted to make sure that they had justification for starting it. Now, with the advancement in ART, the decrease in a lot of the side effects, taking other meds to battle the side effects, all HIV positive cases that present to the medical clinics must all initiate therapy right away. So that's something new. And we talked a little bit about the superinfection is the one I was talking about where you can get other strains. It presents quite a challenge to medical doctors because now they're starting to take a handful of medication. And the only thing I want you to know about this is that patients who are HIV positive are 3 times more likely to, let's start with the sexually transmitted infection, because we don't call them diseases anymore. We know they're infections. So it's STIs now and not STDs. But when an STI is present, they're 3 times more likely to seroconvert to HIV. So even with STIs present, they need to have protected sex and activity, okay? And obviously you become so immunocompromised, but where we see the concentration of HIV is in the genital fluids. And of course, that's the mode of transmission. And so that's why it's 3 times more likely. All right, quick risk assessment, because you're going to get a lot of it here. And I got a lot of this information from your instructor. But this is what you want to do every day anyways. We risk for bleeding, risk for infection, drug interactions, and tolerability to treatment today. So they were fine for a quadrant last week. They're in today. You do it again. Talk to them again. How are they doing? Are they on their meds? And I would say, wouldn't you agree, this applies to all MedComp patients. They don't have to be HIV positive. Yeah, and a lot of when we say medically compromised, is because conditions go hand in hand often. So you don't just look at them as a diabetic patient, because most likely they've got, other conditions along with it. And I'm gonna, So opportunistic infections, you're going to get a lot of that in your pathology course. So I'm going to just skip through the 4 or 5 slides I had for that. And we talked about standard precautions. I want to just talk about this for the next 5 minutes. And that is when you get an exposure. And this is the take home, because we get there's a needle stick upstairs in the clinic. I'm going to venture to say at least 1 a day. Between all the clinics combined, there is a needle stick, and Mary Hartwell's office will process paperwork probably about 1 a day. So post-exposure prophylaxis does not talk about only needle sticks. There are other ways to get exposures. But what you want to do is you want to use therapeutic agents, ART, to prevent infections following an exposure to a pathogen.
And those are the different ways that you can get an exposure. Most of them will be percutaneous in the skin with a needle, but you can do splash both mucosal and non-intact skin, because we already said on intact skin you can't transmit the virus. So if you get a splash on mucosal or non-intact skin, it's an exposure. Let Mary Hartwell know. Eyes, mucosal. And of course, bite. We forget about that. Bite's an exposure. And you know, usually it's children, but most of my career I also treated handicap, what we call MRCP, mental retardation and cerebral palsy patients. And trust me, I got bit a lot. And so bite is an exposure, and if it breaks the skin, okay? And there's 2 PEPs now, one for HIV and Hep B. But of course, we're a lot more concerned about the effects of Hep C. And you all know now that there is actually a cure for Hep B. All right, here is that risk chart that Mrs. Hayton was talking about. The percutaneous exposure of all of the cases, only 0.3% seroconverted. And these numbers are before PEP was available, because now most of these exposures initiate PEP. So we'll never know if they're going to seroconvert, and that's the whole point, isn't it? But before we had PEP, about 0.3%. So all of these factors have to be in place. There has to be a large volume of blood that has a large concentration of viral load. It has to be a deep exposure into a vein or artery. That's when all of the risk goes up. And you can see how negligible the mucous membrane and the non-intact skin exposure seroconversion rates are. It's important for us as healthcare workers, because when you get one, when you get it in the eye, trust me, all these numbers go out the door, right? Even though you see that it's less than 0.09% chance that you're going to get HIV, you get it in the eye. At my clinic with an HIV positive patient, I've seen it over and over again that everything I show you up here goes out the window. And we got to sit down and we got to have a discussion. And at the end of the day, it's going to be your choice. And I don't care about the numbers either. At the end of the day, you're going to look at everything that's before you. We're going to look at the patient, their health, your health, the exposure, and then you're going to make your decision. I'm going to support you 100% what you want to do, whether you start PEP or not. Okay. And here's a list of things that are infectious fluids. And here's the numbers. 57 documented cases of healthcare professionals, HCP, that actually seroconverted, 57 cases. Those are the numbers, the percentage numbers we're talking about. These were all percutaneous, and no dentists or dental workers have ever seroconverted from an occupational exposure, percutaneous occupational exposure. Are there dentists who are positive? Absolutely. There's been many in the news, especially a long time ago. There was a dentist who was positive and decided he was going to take out as many people as he could because he was just so angry. Yes, and he did not use protection when he treated his patients. At the time, gloves were not mandated, and so he did not take extra precautions, and he did give it to a patient, and one of them was came out in public and let the media follow her decline until she died because she wanted to bring education to the public about this. But what it did, right, was it scared people to go to the dentist, and the public awareness she brought really caused a mass panic across the country. So instead of saying, you know, there's ways to prevent this from happening, she took an example of someone who did it intentionally. Okay. We already know 13% don't know that they're aware. So that means there is a 13% chance, they have to be walking around positive. But at the end of the day, what you need to know is that somebody can sit in your chair and they not even know they're positive. They don't even know. When you come to our clinic, you're going to hear a patient interview. So you're going to come in small groups, and we have a patient come in, and you get to interview them.
I always ask the patient, before you go in, are there any questions that are off the table? Do you not want them to ask you how you got it, about your sexual orientation, about any way that you're living your life right now? And do you know they always tell me, nope, nothing's off the table. Because the people who agree to be interviewed, sometimes it's their first time really talking about it in public, but they want to help and they want to educate us. They want us to know what they've gone through. And so to this day, there's never been anyone that says, yeah, don't ask me personal questions, I'm not ready for it. They go in and sometimes that's the first time they talk about personal things to people that they don't know. Yes?
So when we go in your clinic, or not your clinic, I'm sorry, when we do rotation
Yes.
review, are we cleaning people's teeth?
Yes.
Teeth and talking to them?
Yes.
Or,
Yeah.
okay.
So I'll talk about it. If this happened on intact skin, I'm just quoting exactly what the CDC says. PEP is rarely, if ever, warranted on intact skin, low risk exposures where you live in an area where HIV prevalence is low, and if the patient's negative, please do not start PEP. It's the only strong thing that I can say about PEP. If the patient isn't tested and is negative, then I always get the question, one of you is probably thinking it, what about the little window where they don't know that they're positive? Because of the way we know that we can test them now, if they take any one of the Genius assay tests and they come up negative, they're negative. They're considered negative. Okay, I gotta go quickly. These are all the things you have to keep in mind if you have an exposure. Keep this PowerPoint with the caveat, please look at how things change all the time. The things that matter to you as a dental healthcare professional has not changed since I started teaching the class, meaning, you know, how you decide whether you're going to start PEP or not, but keep the PowerPoint in one of your USB drives or in one of your folders on your computer where you say, I want to know that it's there. When it happens, I know what to do. It's most effective within 2 hours of exposure. You got to take a 8-day dose unless you find out they're negative. Stop. And we know that it's 28 days because they did tests on monkeys. And this is the regimen that they're still using. If you have PEP, this is the most important slide. That's not. This one's the most important. There's a phone call that you can make and have someone talk you through all of it. Like what I would do it when you come to our clinic and if you have an exposure. And I'm just going to tell you right now, every year we have an exposure among the students. So we're going to go over all this again before we go into clinic because we don't want to have an exposure ever. But if you have an exposure away from us, there's a phone number. This is the one slide you want to keep somewhere. There are 3 laws that protect patients with HIV. The Americans with Disability Act. HIV and AIDS is one of the few conditions that is specifically mentioned in the ADA. Okay? Because of the long history of the stigma that they've experienced. OSHA, of course, and HIPAA. Privacy is extremely important. And there's numerous cases where this was violated by healthcare professionals and patients have sued. This is where you're coming to the SAC clinic. This will be on the HIV Canvas site for our rotation. It's the beautiful new building on G Street. You can see it from the freeway. And this is my grant, the Ryan White grant. It all started in 2002. It was named after the young boy who was a hemophiliac and had a blood transfusion that was tainted with HIV. And then just a stigma he went through of no fault of his own, where the whole school system wanted to keep him out of school. And so he and his mom came forward. His mom still attends a lot of the HIV meetings. He, of course, passed in 1990. And then the government, he died only a few months before the government enacted the Ryan White initiative, where they started directing money. In all, the Ryan White program has $2.3 billion in funding every year. It's been renewed this year, but $3.2 million is in the Part F, and that's what we do. 11 dental schools have it. We're one of them. We've had it for 16 years. All students in this building come through the rotation. It's 8 hours. And one of the things that we can do is use our money to get special care for procedures that are not covered by regular dental insurance. So we send our patients for a lot of oral surgery, perio surgery, root canals, lots of root canals to try to save their teeth. And if you want to know if it's working, what percentage did you see were virally suppressed of people who are retained in care?
57%.
Yeah. Those in our Ryan White program, we're at 85.9% that they're virally suppressed. The program works. This is just a piece of it, and this is the Ryan White impact. The goal is ending the HIV epidemic in the U.S., and we won't have time to do this case study. What I'll do is I'll save this, and you'll do this when you come to the rotation. I want to make sure I've answered every question about the rotation. So you said when we come...
We'll be working on the patients, but as well as being able to communicate and talk to them.
Okay, yes. So your first half of the day, so it's a Wednesday all day. Your first half of the day is a classroom experience, although most of it is, there'll be very little of this lecturing. They're going to hit some high points, and then we're going to bring in a patient for interview. You're going to look at charts of the patient for the next day as a group. And we look and we see what's missing, what questions are we going to ask tomorrow. A lot of them come in without the labs. I don't like to see patients without their labs, especially in the Ryan White program where those outcomes are, we have to report them every year. And so when someone comes in for their dental appointment and does not have updated labs, then looking at the chart the night before, we can start getting that rolling. We contact the patient. Usually they have it. Usually they have the paper. They're going to walk it in with, with the appointment. But we want to make sure we have labs that day. And so we'll go over the charts. And then you're going to get a case study to work on in a group. And it's a little bit of a homework. But if you are familiar with what we've been talking about, there's a good, you're going to have about 90% of it ready. And you're going to work and do a case presentation the next morning. Sorry, we used to be 2 separate days. Now it's in the afternoon. You're going to come back from lunch and you're going to do case presentations, and then we're going to go into the clinic and treat our patients. And the way that you're coming in 6s, and we've got 3 operatories, 3 chairs, you'll be paired up to work on patients. And it's all hygiene only. They've been pre-diagnosed by the attending dentist from Saks. His name is Rodney Turner. He's been treating solely HIV patients for 20 years. He's had 6 very serious needle sticks. And he usually comes in on the first half of the session of the rotation, and you can ask him what he's done about that. And he's so knowledgeable. He's really great. So sometimes he gets busy and he misses a rotation, but most of the time he'll come into the classroom and spend a few minutes with us and tell us about his experience working on HIV patients for 20 years. And then post-survey, and that's it.
And I'll post the new PowerPoint, and I have slide numbers on some of those. I'll look over that and repost them. Okay?
Shelley, can you do one thing? Before you clap, thank you. One guy was like ready. Can you do one thing for me? Can you answer these 3 questions? I won't show the results. Can you just answer these 3 questions for me on this poll? Sorry. And let's just do them really quickly. It's this one. I won't show results, just activate it. Okay. Yeah, sorry. Hey, my daughter's FaceTiming me. Can I answer this while you're doing that? Okay. All right. Hi, sweetie.
Are you in a meeting?
Show her.
Hi.
Okay, bye.
Bye. She's coming home from spring break. I'm going to pick her up at the airport tonight. Yeah, it's my girl. Okay, next one. Oh, 24. A few more. Come on, just give me.
How you doing?
Objectives were met. All right, that's good. And then how about this next one? I don't need results, just activate. they're general questions, but be honest, and then I kind of know that I'm coming off not knowledgeable. Okay? 35, thank you so much. One last one. Activate. Thank you so much. Is the topic relevant to your practice of dentistry? Are they good to go?
They're
All
good
right.
to go.
Thank you so much.
Awesome. We never have enough time. They're very appreciative.
Goodness, they challenged me.
They don't mind talking to you.
Take some food on your way out.
Maybe if you don't mind sending that to me now so I don't forget either.
But I know I sent it to you because that's how I opened the right one.
What?
Yeah, look.
I opened the one you sent me last night.
Thank you.